A topic that comes up really in many ICH patients is whether surgery would be beneficial. Should we ask our neurosurgeon to take out the hematoma? So this has been the subject of 2 large clinical trials published in the last decade or so. The first was called STITCH, and this was really a pivotal study mainly because it showed that we could do a large randomized trial in ICH. But as you'll see, the results have still left us without complete clarity on the role of surgery. STITCH enrolled over 1,000 patients with supratentorial intracerebral hemorrhage. And they said, we're going to test a policy. Should early surgery be done, or should we use early medical therapy and only do surgery later if we think we need to? So technically, it was not a study of surgery versus no surgery. It's a study of early surgery versus not. And this is the outcome. STITCH found that there was no difference in mortality at 6 months, and there was no difference in functional outcome. So this really has made surgery not look particularly appealing, but there's some caveats here. 1 out of 4 patients who was initially randomized to early non-surgery, early medical therapy, got surgery later. So all we can really conclude here is that early surgery is not harmful, and there's no evidence favoring early surgery. STITCH 2 took a subgroup of patients from STITCH, patients with lobar intracerebral hemorrhage. And they looked at, because there was a suggestion in that trial that maybe these patients actually did benefit from surgery. And it was a very similarly designed trial, although if you see, these were patients who were awake, who were not particularly severely affected. Some of them, though, were worse than others. They looked at this early surgery versus not early surgery. And even in this trial, about 1 out of 5 patients who didn't get early surgery ended up getting late surgery. But there was no statistical difference in outcome. You can see it's very similar across the range of outcomes. But they did do something, and this was a post-hoc analysis. What they said was, we're going to go back and look at the subgroup of patients who would have been predicted to have a poor outcome based on this mathematical equation they developed from the original STITCH trial. And they said, if we looked at just these patients, the poor prognosis subgroup tended to benefit from surgery. So this was an interesting finding, although because it was a post-hoc analysis, it can't really be used to say we should definitely do surgery. But it is interesting. And I think when we developed the guidelines for surgery for the 2015 American Heart Association ICH guidelines, we recognized that there was still ambiguity around whether surgery is going to make a difference or not. I'm going to draw your attention to one thing very, very important. Before we go on and talk about supratentorial ICH, the guidelines recommend that patients with cerebellar hemorrhage who are deteriorating or have brainstem compression or hydrocephalus should undergo surgical removal of the hemorrhage. And this is a class 1 recommendation. STITCH and STITCH 2, we're looking at patients with supratentorial hemorrhage. But we recognize that patients with cerebellar hemorrhage can be very salvageable, even if they look really bad at the time. And this is really, really important. Do not be reluctant to do surgery on these patients. It can be life-saving. It can also make them so that they can recover very, very well. There hasn't been a randomized trial to test this, mainly because we haven't felt like it was even ethical to do that. So cerebellar hemorrhage is a surgical lesion. What about other patients? Well, we said for oral ICH, the usefulness of surgery is not well established, and a policy of early hematoma evacuation is not clearly beneficial compared with doing it later. And later was generally considered after 6 to probably 24 hours. But there are a number of different other surgical techniques, like decompressive craniectomy or minimally invasive clot evacuation using stereotactic approaches, that may be out there that haven't been fully studied. And there's a fair amount of enthusiasm right now for this idea. Can we do a stereotactic approach and take out the clot by using minimally invasive techniques that don't damage the brain going in? So here's a hemorrhage, and here's the removal. And so this is very enticing, and this is being studied now in a randomized trial called MISTY. And there are other studies that are being organized in order to test this. But we still have things we don't know about ICH surgery. First of all, despite the large STITCH and STITCH 2 trials, we still don't know if surgical hematoma evacuation helps patients. Okay. The question, does the type of surgical intervention make a difference? Open craniotomy versus minimally invasive versus just taking the skull off. I think that some of these new trials are going to give us information, but it's going to take a few years. And I haven't heard anybody who's really been willing to do a randomized trial of surgery for cerebellar ICH and randomize patients to no surgery. So for now, we really need to consider cerebellar ICH a surgical lesion while we are working all of these other things out. I do want to continue with a few things as we conclude the talk. As you've seen, we have a number of randomized clinical trials for ICH, and that's been a very important advance. But unfortunately, none of them have shown a perfect treatment. The ones that have shown potential benefit have been fairly modest. And one of the problems that has occurred, at least in the United States and Europe, is nihilism. Saying, well, we don't have a big treatment of proven benefit, it doesn't matter what we do. So we and others have looked at this and have found that patients who are not treated aggressively turn out to do worse. And so one of the problems that happens, and this may be related to particular cultures in different parts of the world, but there's something called a do not attempt resuscitation order. And that basically means that if a patient has a cardiac arrest, we don't try to bring them back. And it's often one of the first things on the continuum to say, we're going to move to hospice or palliative care. But there's evidence that if that's one of the first things you do and you limit care, patients do worse, regardless of other factors. So the guidelines now recommend aggressive treatment on all patients. The exception would be a patient who comes in with prior advance directives. So if we have a very elderly patient where they've discussed it with their family before, or a patient with other bad conditions such as cancer, who's at end stage, and they discuss it with their family before, and they say, we wouldn't have wanted this. I understand that. But otherwise, we ought to be treating patients aggressively up front because it does make a difference. The other thing I'm going to mention, and this comes from our 2015 American Heart Association guidelines, is prevention after a patient has an ICH. Remember we started to talking about blood pressure? Well, we're going to finish it up talking about blood pressure. Measures to control blood pressure should begin immediately after ICH onset. And our target long-term is going to be pretty aggressive. We would like to keep patients below 130/80 if they've already had an ICH. That's long-term, okay? And that's because of a study called SPSS, which suggested that that target, that very aggressive target, can really help prevent recurrent stroke. And then the other question that comes up, what if somebody was on an anticoagulant and we reverse them? Do we ever restart it? Well, we recommended waiting at least 4 weeks to restart it. So we could treat patients with aspirin until that time. The exception would be someone who has a very strong indication, such as a mechanical heart valve, where we may start earlier. I want to finish up by bringing your attention to something called ENLS. We've been talking today about ICH, intracerebral hemorrhage, as a neurological emergency. And the Neurocritical Care Society developed a program And this is available online. There are also in-person courses, but it's an online course that focuses on what to do in that first golden hour of a neurological emergency. And there's an ENLS module that you can take online on intracerebral hemorrhage, but on 13 other categories, such as traumatic brain injury, seizures with status epilepticus, how to evaluate the patient in coma, and so forth. And if you're interested in learning more about neurological emergencies, I would encourage you to take a look at ENLS, because we think it's a useful program for doctors and nurses, trainees, in order to understand more what to do in that golden hour of a neurological emergency. So to conclude, intracerebral hemorrhage, ICH. Well, first and foremost, high blood pressure is the most common cause, and most ICH is preventable with good hypertension management. We would love to prevent this from happening in the first place. But when it happens, acute ICH management includes clinical classification, probably using the ICH score, radiological classification. Remember, you now know how to calculate hematoma volume, ABC over 2. Blood pressure treatment, coagulopathy reversal in those patients who are on these medications, and surgery in selected patients, especially those with cerebellar hematomas. And I just want to emphasize that research in ICH treatment is advancing rapidly. So hopefully next year, the year after, this talk will be different, and we'll have even new treatments that we can deliver to our patients. So thank you very much for the opportunity, and I wish you best wishes in your care of patients with stroke and other neurological emergencies.